I'm going to talk to you about non-epileptic seizures, communication and ethics. I can't remember whether that was my title, but the closer the meeting came, the more I got worried about the ethics. So I thought I'd declare straight away that I'm not an ethicist. Last Tuesday I went to the library, I got 5 books out. This was one of them, Medical Ethics for Dummies. And I've only got to page 11. Which told me about the 4 principles of medical ethics. So this is as far as I've got with my explicit understanding of ethics. But I think that actually carries a fair distance and can be applied to much of what I want to talk about. So the 4 principles of medical ethics, I'm sure, are known to most of you. Autonomy, beneficence, and non-maleficence, first do no harm, and finally justice, about the allocation of resources. So I've brought you a potpourri of stuff in multiple colors. When we're on green, it's time nearly to go home. I'll talk first about dilemmas around history-taking, and then secondly about dilemmas around the communication of the diagnosis, both of which are topics that have featured today already. And then finally, on green, I'm going to talk you through a case to offer what I think might be a solution to some of the problems alluded to in the first 2 sections. So this is mainly for the ethicists, the non-neurologists. Just a bit of background about non-epileptic seizures. They are common. About 1 in 5 of the patients who attend blackout or seizure clinics have non-epileptic seizures. The misdiagnosis rate remains high. It's probably around 20 or 30% on average, but in some settings it's as high as 50%. The mean delay of the diagnosis is, we found, is 7 years. We've recently looked again in the UK, it was 5 years. So most of the patients we eventually diagnose as having non-epileptic seizures originally carry a diagnosis of epilepsy and are treated with anti-epileptic drugs. We've described a case of a 24-year-old who died because of inappropriate treatment of his non-epileptic seizures. Other cases are also known. So this is a serious condition, and the failure to diagnose it can have fatal consequences. Now, how do we make the diagnosis? The traditional approach is to try and capture an attack, for instance, with video EEG. But of course, this is not accessible to everyone, and it only captures attacks in 2/3 of the patients. In some centers, people try to increase the rate of diagnosis by using saline provocation methods, but that's the one topic in this area about which there is a lot of literature, ethical literature, about the procedure. So I'm not going to touch on this much, except to say that most ethicists don't think that that's the best way forward, and I agree for a number of reasons. So what it boils down to is actually that in this area of medicine, pretty much everybody agrees that history-taking is still the most important tool. So what does this involve? Considering that history-taking is so important, you would expect there to be a large body of literature about how we should take the history and how we should interpret it. But I guess most of what you find would be lists of facts that you might ask about. Did you injure yourself? Attacks from sleep? Do you lose control of your bladder? Do you bite your tongue? How long do they last? Are your eyes open or closed? Is your mouth open or closed? Do you go blue? Do you frothing from the mouth? All these sorts of questions that we ask. Problem with these questions is that in the first row there, you've got the sort of favorites, traditional favorites, but they've all been shown individually not to differentiate between epilepsy and non-epileptic seizures. They work quite well in the differentiation of fainting and the other 2 conditions, but not well between epilepsy and non-epileptic seizures. And then in the bottom 3 rows, you've got items which have been proven in studies to differentiate between epilepsy and non-epileptic seizures, except they've been proven to work in video EEG studies when you have video evidence. Other studies have been done which have looked at what happens if you ask patients or witnesses about these items, and invariably those studies show that these questions also don't work. So for instance, eyes are open in 90% of of epileptic tonic-clonic seizures. They're closed in the vast majority of non-epileptic attacks on video. But if you ask patients or witnesses, are the eyes open or closed, you're not going to get accurate information much of the time. So actually, it isn't a very good differentiator if you haven't got a video. So there are issues with our standard approach to history taking. And that may explain why we get so many things wrong. This standard approach, which is a sort of question-answer series, is also extended to the search for causes. Sigmund Freud wrote about the search, in fact, he thought he'd discovered the source of the Nile, the holy grail of the neuropathology of hysteria, when in his early days he thought that hysteria was due to premature sexual experiences. He withdrew this opinion later and then changed it several times during the course of his career, but that's just an aside. So what tends to happen is doctors ask about these things. They extend their list of questions to lists about to questions about trauma, anything happened, and some actually recommend inquiries about sexual abuse. This is really just an ethical warm-up. So what's the background to this? Well, a history of sexual abuse has been shown to be a risk factor for non-epileptic seizures, if you're looking at the differential diagnosis of epilepsy and non-epileptic seizures. If a patient admits to a history of sexual abuse, then that's 3 times more likely in people with non-epileptic attacks than epilepsy. But you can see at the bottom there, the largest study that's looked at this found that the vast majority of people with non-epileptic seizures have not been sexually abused and not been physically abused either. So it's a risk factor, but it's only a factor in the minority of patients. So what I wanted to do with this particular item is just to play around with my limited knowledge of ethics and just run through the 4 principles and how they apply. So should doctors inquire about a history of sexual abuse? Well, I've just shown you that it is a risk factor. There was a big meta-analysis, and it's 3 times more likely in people with non-epileptic attacks, so you could argue that it contributes to diagnostic certainty. And, of course, if it's present, then patients may realize, well, I can see how this might relate to my attacks, and that might help them engage in treatment. We do have some evidence for this from a study where we interviewed patients after they'd received the diagnosis from a range of doctors, and we asked them about how they felt at the time. And some, because the doctor had mentioned it, felt they could see how their seizures might be related to this trauma. And you could argue that the openness would strengthen the doctor-patient relationship. And in fact, there may be real-world reasons why it's important to know. I have come across several cases where abusers were still around, still living in the family, still up to no good. So, the sooner you bring it out, the sooner you can protect your patients and others. But there are also some arguments against. You are certainly interfering with the patient's autonomy. The person asking is the doctor. The doctor would be a person who exerts, willingly or not, quite a lot of pressure on the patient to answer. So you might get information from the patient wouldn't really have wanted to share. You may activate a memory that may destabilize a patient who feels that they've dealt with this and who've come to some kind of accommodation with their history. In fact, because they feel, I've dealt with this, it can't be that, it may not help them at all to accept the diagnosis. I've said that 3/4 of the patients with non-epileptic attacks have not had a history of sexual abuse. You may alienate those patients, and you may in fact confirm to those who don't really believe you about the diagnosis that, well, doctors ask about sexual abuse, that never happened to me. My childhood was fine, so this doesn't apply to me. And in fact, there are studies that have looked at the prognostic value of disclosure, and disclosure alone without any follow-up has never been shown to improve any outcomes. So I think what I wanted to do with this is demonstrate that you can apply these 4 main principles of ethics to issues related to history taking, to specific issues related to history taking. I suspect that you'll come down either in favor or against, depending on the particular circumstances of the patient and where you see them, who you are, who the patient is. But I'll show you later that in the way that I communicate with patients, this consideration doesn't actually matter much. So the wider question, not specifically about particular traumatic experiences. How should we take the history? Surprisingly, there is no particularly good literature on this. There is a traditional way of asking this, of going through the history, and I've already said what I think that is. These question-answer sequences. And what I'm going to talk to you about is an alternative way of doing it. First of all, I'll play you just a taste of traditional history-taking, first few minutes of an encounter.
You're the patient. Hi. I'm Dr. Hills. Nice to meet you.
Nice to meet you.
Good. And I work with Dr. Grunwald, and we've had a letter from Dr. Prasad to treat him. Mm-hmm. And it says you had a blackout in August.
Yeah.
How old are you now?
I'm 20.
And what do you do for a living?
Well, I'm a student, but I work at Asda at Sheffield.
So what's your student on?
English.
So is that at Sheffield University, Hallam University?
I'm at Hallam University.
So that seems innocent enough. But I would say there are a few issues with this. The doctor is establishing a pattern of interaction where the doctor is firmly in control of the topics and the patient gives answers. If you do that, then you will get answers, but you will only get the answers. There's also more going on here. The question about the university, there is a proper university in Sheffield and there is a university that's not so proper. This lady is from the university that's not so proper. So, there are some sociological issues going on here that enhance what I've just said about the doctor controlling the interview. So the alternative approach that I want to talk to you about is something that was originally proposed by doctors in Bethel at the Epilepsy Center in Bethel in Germany. They were based on some psychodynamic considerations and good practice. Many German doctors have now been trained to apply this method, but as I said, there isn't any strong evidence that this is better than the traditional method. I think there are conversational reasons why it might be. We have translated this into English, and we carried out a series of studies, which I'll briefly summarize for you, using this method. And then at the end of my talk, I will show you one particular interview in greater detail. So this alternative approach starts with an open question. In our studies, we were dealing with inpatients who had been admitted for video EEG because a fully trained neurologist had assessed the patient and didn't know whether they had epilepsy or non-epileptic seizures. And all the people included in our studies did eventually have a spontaneous seizure during the period of recording that allowed us to make a firm diagnosis. So they all had seizures with loss of consciousness, and we had good video EEG data. So we had gold standard medical diagnosis on these patients eventually. And during their period of video telemetry, when I didn't know the diagnosis, in fact, when they hadn't had any seizures, I had a conversation with them following these guidelines. The conversations were recorded and then analyzed by a range of different linguists. So my opening question to patients was, what were your expectations? What expectations did you have when you came to the ward? When I use this method in outpatients, I may say, how can I help you today? What can I do for you? So an open question that doesn't mention seizures, it allows the patient to answer the question in a wide variety of appropriate ways. It gives you the opportunity to see what exactly the patient will start talking about. and how the conversation pans out from there. And then the rules are not to interrupt the patient, let the patient talk. If the patient stops talking, first of all, to tolerate silences. And I'll play you some just to show you how painful that is. And to use reception indicators like right, okay, at times when this seems appropriate. And if all else fails, to repeat the last thing or a thing the patient's already told you. So you're saying you black out in these attacks, or you're saying you fall over, to try and indicate that you want to know more and more detail, but without changing the flow of the conversation. Avoidance of additional questions as part of this, other than for clarification. And especially avoidance of new topics, so that you can focus your attention on what the patient says and what topics the patient talks about. So after this initial open phase, which in our study used to take 10 to 15 minutes, we would then prompt the patient to talk about specific attacks. Can you tell me about can take you back to the first seizure? What happened there? Again, very open question. You could just say, well, that was 1985. Or you could say, well, the first seizure was at my mother's house and I was doing that. Or both are appropriate ways of dealing with the question. Same last seizure, then worst seizure. And then finally, we had a challenge, something like you say you black out in the attacks. What do you mean by blackout? Do you mean that you're completely out, or that you can not respond but hear what's going on? So again, you pick something up and you see whether you can induce another bout of information provision, or whether the patient doesn't tell you very much. So that's really what the doctor has to say in the interview, but that's not entirely sufficient for this method to work. It is important that the doctor has an understanding that the aim of this is that the patient has enough discourse space to determine and to focus on what is most relevant to them. So the patient decides what's relevant to them. Our study has since been repeated in Italian patients, and the Italian doctor had great difficulty not letting them talk, despite the patients being Italian. So that means that the doctor really has to check his natural desire to control the patient's narrative. These interviews are done in the real world. The real world sociology applies. The doctor is in charge, naturally. And wants to be. So the doctor has to work hard not to butt in. Instead, the doctor can pay attention not only to what the patient says, but also how it is reported, and what communicative strategies the patient uses. And I'll show you some examples. And especially, it is worthwhile to pay attention to those things that might otherwise be considered irritating. So patients who repeat themselves, pauses, reformulations, gaps, incomplete or disconnected narratives. That's all great. All this contains important diagnostic information, and that's exactly what we want. And that's exactly when your urge to interrupt the patient becomes maximal. So that's exactly when you have to focus on what's happening rather than interrupt. And with this method applied to patients with epilepsy and patients with non-epileptic seizures, we found a large number of linguistic or interactional features which help differentiate between these two groups. And these are just 4 of the most important ones. So with the open question, patient with epilepsy focus on their seizure symptoms. They maintain the focus on seizure symptoms. The people with non-epileptic seizures tend to focus on the consequences of their attacks or the situations where they occur. I'm having them in the street. I can't go out anymore. I've had them at the top of the stairs. In fact, when you try to focus them, tell me about your first seizure, last seizure, worst seizure. Well, I can't remember. They're all the same. They're all bad. You don't get any extra information. The subjective symptoms, when given by people with epilepsy, are given in great detail, but people with non-epileptic seizures show this detailing and block. You may get, well, I feel dizzy, I get a violent headache, and then I'm out. So, okay, so can you tell me a bit more about it? Well, I get dizzy, I get violent headache, and then I'm out. And you don't move beyond the labels that they use. Formulation work is extensive in epilepsy. I get these funny, it's like, how do I say, it's a bit like... but it's not. So, restarts, hesitations, reformulations. In non-epileptic seizures, you tend to get, well, and then I'm out. And then when I came round, so there's sort of total gap with little detail. If there's a gap in consciousness, which would be a particular challenge to communicate, then people with epilepsy try very hard. The last thing I remember is standing in the kitchen. Next thing I know, I'm in the dining room, and I don't think I was out for very long because so they volunteer a reconstruction of the scene, whereas the people with non-epileptic seizures would tend to leave this out completely. So these are just some examples. There were many more. And I'm just going to show you some examples now. I showed you the opening sequence of traditional history-taking, and now I'm going to show you the opening sequence of a conversation with David.
I wonder whether you could tell me what your expectations were from coming here this week. What were you hoping to get out of it?
Expectations? Find out why I get these reactions. I've had encephalitis 18 months ago, and ever since then I've been having a reaction. Because which I thought was epilepsy. Some of them must be, I think, are, but some of them I don't think are, because I can stop them myself. Right.
So he focuses immediately on his seizure symptoms without any prompting. He also volunteers the fact that he can suppress seizures, which is something that we saw much more often in people with epilepsy. Next is an example of a conversation with Chris. This is 9 minutes down the line. Up to this point, he has only provided minimal details of what actually happens, and he has hardly used any nouns. So he says, "Oh, I'll just have them. They just happen. It just occurs," without actually saying what it is. And of course, my question didn't mention it. So after 9 minutes, we're at this point here.
So you say you black out?
Yeah.
And you fall to the floor?
Yeah. I don't get no warnings. And when I come round I feel really tired and confused. And in a lot of pain.
You feel a lot of pain? What?
Yeah. Like when I felt me forget myself.
Right.
So I'm leaving long pauses, and you could see how painful 7 seconds are in the sort of in interaction. It's an enormously long time. We have examples of 32 seconds of pause. So the speed of these encounters is considerably lower than the speed in which you get the normal question-answer sequence. I'm picking up things that he said before to try and prompt a bit of extra description, but I'm getting minimal joy with that. So I'm just going to very briefly mention a number of different studies we've done on the same material. So we had these 20 or so recordings of these conversations. We had gold standard diagnoses in all of them. One thing we looked at was metaphors. So we found that we could most metaphors that people used about their attacks could be divided into 3 categories. Into the categories agent, force, event, situation, or space, place. Agent force were things like, oh, the seizure comes on, seizure pushes me over, seizure creeps up on me. So in these metaphors, the seizure is an agent, has agency, does something to the patient who's the victim of the attack. In the event situation metaphors, the seizure happened, the seizure occurred, there was a seizure. So in these metaphors, the seizure also has agency, but the patient is a witness of the attack rather than the victim of the attack. And in the metaphors of space or place, I go into the seizure, I come out of the seizure, I'm in the seizure, I can't get out of the seizure. We identified, I think, 800 of these metaphors in the material. We found that most people used most metaphors, mixed them happily. But when we looked at the relative preference, we found that people with epilepsy preferred metaphors in which the seizure had agency. And especially metaphors in which the seizure turned them into the victim of the seizure. And with the non-epileptic seizure patients, we found that they preferentially used metaphors in which metaphors of space or place in which they were in the seizure. So in these metaphors, they have the linguistic agency. They go into the seizure, they come out of the seizure. So that was one approach. We also looked at the labels that people use for their attacks, and we found that the most popular labels were for seizure, fit, attack, blackout. We saw that they're not used interchangeably. So seizure was by far the most popular label used by patients, and these other labels were used less commonly. So the different distribution suggests that these are not words that are used randomly. They have meaning. They're used with some kind of direction and thought. And then we went on to establish what the meaning was. We found out that that seizure and attack are generic. They could be used for episodes where you just flop down to the floor, or episodes where you shake on the floor, whereas fit and blackout were more specific. So blackout was flopping to the floor, and fit was involved shaking. We also found out, and that was a bit more surprising, that seizure was a medical term. So people, they were saying things like, I started having seizures, but I didn't know there were seizures then. Or, I had a blackout at home, and then the ambulance came, and the ambulance driver said, oh, he's having a seizure. So seizure was a term that had to be sanctioned by a health professional. And then we identified this curious issue that people with non-epileptic seizures had a problem with the word seizure. They didn't like using it very much. So whereas all people with epilepsy volunteered the use of the word seizure, over a third of people with non-epileptic seizures never used the word seizure. Whereas all the people with epilepsy self-initiated the use of the word seizure, only 46% of people with only 54% of people with non-epileptic seizures self-initiated the word. And then there was sometimes a resistance to the use of the word seizure. Again, in almost a third of the people with non-epileptic seizures, they would say things like, and then I had one of my seizures. So there'd be a hesitation before the word of the seizure. Or I had one of my seizures, or whatever you call them. So there would be some kind of mitigating additional comment. So there are differences on group level in the use of the word of labels, in the use of labels. Most recently, we've done a study where we've looked at all third-party references. So these were conversations between me and one patient, so there was nobody else present. But because these are consultations about seizures, others are mentioned very often, especially when people black out. They often say, and then so-and-so found me, and my husband said I was out, and the ambulance drivers came and said X. So in total, we found 510 such references in our material. And the interesting thing we found there was that people with non-epileptic seizures, dissociative seizures, they tended to use these references to catastrophize, to dramatize their seizure accounts. And whereas the people with epilepsy tended to use the references to normalize the seizures. So they would say things like, and I know this other guy, but he's much worse than I am. Or, I had my seizure, we were watching television, but my husband, he didn't even do anything because he's used to them. And the people with non-epileptic attacks would and then you get examples later, and then so-and-so had to come and had to revive me, had to give me the kiss of life. So we put together a scoring sheet encouraging linguists to look at these specific issues one at a time, then score each issue, and then come to an overall view whether they thought that the transcript they were looking at, and that's all the information they had, was of a patient with epilepsy or a patient with non-epileptic seizures. The linguists, one was Italian and one was Dutch, so they were blinded to English, you could say. They got 85% of the diagnosis right, which is astonishing given that 60% of these patients came in with the wrong admission diagnosis. So the consultant neurologist who had the notes and before the video EEG had given them the wrong treatment. I mean, he must have had an inkling, I guess, otherwise they wouldn't have been referred. But these were people with the wrong working diagnoses to start off with, and the linguists got them right, with no idea of how to interpret tongue biting or frothing from the mouth or all these epilepsy-related facts. We also did a quantitative scoring, and this tool performed with reasonable sensitivity and specificity, and the inter-rater reliability was as good as video EEG, which isn't very good actually, but it's moderate, it's acceptable. So now I'm trying to apply this ethical scheme, my ethics for beginners, dummies, to the whole interview style. So in favor of the open interview style is that it optimizes patients' autonomy in interaction, because the patient chooses what they pose as relevant and important. And I've just shown you how much valuable diagnostic information you can extract from these interviews. You don't have to ask all these questions, which I've previously said don't really help you anyway. You can focus on the interaction, and it provides excellent diagnostic information. One would hope that this form of approach enhances the doctor-patient relationship. There are many other studies which show that more open questions are associated with greater patient satisfaction, but that's something we have to show yet. Against it is that if you give the time to the patient, you may forget to ask important questions, maybe about safety and work and driving and contraception, all these other things that might be relevant, family history. Some patients may not like having the space, and often the initial question, how can I help you, is met with an awkward silence. Well, you're the doctor, but you can live with that, and you can say, well, let's hear from you. And of course, this is likely to take a bit longer. I don't think you need to spend half an hour, which we did in this research study. I think if you give 10 or 15 minutes to this approach at the beginning of an encounter, then you probably already get most of the diagnostically relevant information. But it still takes time, in the short run anyway. So, next, I want to talk about some dilemmas around communicating the diagnosis. Just as an aside, I think we should be aware that our attempts to communicate our view of the diagnosis, to reattribute or attribute the patient's symptoms, is in this sort of historical sequence. So presumably the Salem witch trials were very clear that the attacks had something to do with demonic possession. There was no doubt in the minds of the judges that was the right explanation. Otherwise, women wouldn't have been punished. Thomas Willis thought that no, hysteria is actually a medical condition. Charcot thought it was a neurological condition, and Freud had a psychological model of hysteria. And all of these people would have been entirely convinced of the accuracy of their views. And our model is the biopsychosocial model. So we think that people with non-epileptic attacks probably do have a genetic constitution. We don't know what risk factors there are or what resilience factors there are. We've talked about gender already. That's pretty much the only one we know. Then there are predisposing factors. There's often a history of neglect, if not abuse, in early childhood, which leads to problems in later childhood. Early abuse, early neglect is likely to cause attachment problems. That's likely to cause downstream problems with stable relationships, also relationships with doctors. Nevertheless, most of our patients then function for a while, and then sometime between the age of 15 and 25, when most of the seizure disorders start, they are exposed to some often relatively minor precipitating factor, which is likely to only be relevant to them because of their previous experience. There may be physical problems that trigger attacks, fainting spells, epileptic seizures, or other non-neurological physical problems. In older patients, that is especially important. And then you end up with non-epileptic seizures, and then there's a whole host of perpetuating factors which make the problem more difficult to get rid of. So that's the current biopsychosocial model, and different aspects of it are relevant to different patients, or most relevant to different patients. Why do we feel justified to peddle this model? Well, there is evidence that psychological forms of treatment are effective. I'm not showing you necessarily the best studies. I'm showing you our studies, because these are the kind of patients that I see, and that's the kind of treatment they get and the kind of outcomes we see. So we did a study, looked 6 months down the line. What happens if you just explain the diagnosis and nothing else? What happens then? And 1 in 6 of our patients became seizure-free with that. Then we had a psychoeducation program, 4 sessions of psychoeducation by an epilepsy nurse or a junior psychologist, and 1/3 of patients became seizure-free with that. Then we've recently done a longer-term follow-up study of our psychotherapy program, and about 2/3 of the patients 4 years after psychotherapy, 3 years after psychotherapy, are either seizure-free or they have far fewer seizures than before. There are also improvements in quality of life and symptoms and levels of distress. So there's a bit of a dose effect. The more psychotherapy you put in, the better the chances of improvement. And that is what I think. Having said that, if you look at these figures the other way around, you immediately notice that actually quite a lot of people don't get better with these things. So this is not a treatment for everyone in its current, in the way we currently offer it. Still, we apply the psychosocial model to everybody, and we just say, well, sometimes it works, sometimes it doesn't. But that doesn't, on the whole, lead us to consider whether actually the model is right or right for everyone. So we have a clear idea what we think and why, and we have a treatment that is based on this, and we're reasonably happy that it is effective for many patients. Our challenge is that the patients don't have the same views as us. So this is a study where we asked patients whether they thought their problems were physical or psychological. So on the left, you've got entirely physical. On the right, you've got entirely psychological. And then in between, you've got mainly physical, a bit of both, and then mainly psychological. And what you see is that the neurologists have very polarized views. Epilepsy is essentially physical, and non-epileptic seizures essentially psychological. Both patients groups, these are patients with epilepsy or patients with non-epileptic seizures, had slightly more balanced views. And if you look a little more closely, then you see that the patients with non-epileptic seizures actually were more likely than people with epilepsy to hold physical ideas about their condition rather than psychological. So we face a challenge. Only 10% of patients with non-epileptic seizures, or just over 10%, thought that their problems were mainly or entirely psychological. So the majority of patients with non-epileptic seizures hold essentially a somatic view of their condition before you start explaining it. These were patients who hadn't had an explanation. So how do we explain it? Many people have written about this because many people have thought that this is important, and if we do it well, then we can improve outcomes. There's a proposal from Cleveland by Shen, which is the first of these, but other people have put forward proposals. What I think about the way to present the diagnosis is also colored by the last study there, which is a study we did where we interviewed patients after the diagnosis, and we asked them what they thought or how they understood their condition at this point. What I'm going to talk to you about now is 2 studies based on the same data set. So we recorded 20 consultations in which neurologists were going to explain medically unexplained symptoms to their patients, and 17 of these patients had non-epileptic seizures, so that's pretty much everybody. The neurologists involved in this study were 3 experienced neurologists with particular interest in this area, including myself. We've wrote a paper about the patients' contributions to these encounters and a separate one about the doctor's contributions. So I'll quickly skip through those. We found that these encounters had a clearly predictable structure. The neurologists go over the history again first, which is interesting because it's unnecessary. These are all follow-up visits, so the history had already been taken, but yet the doctors take it again. And then they say what the diagnosis is, then they explain the diagnosis, which is also interesting because if you break a leg, you just say your leg's broken. You don't say your leg's broken because you bent it and then it snapped and and the bone is now disjointed. And then the doctors make treatment recommendations. So the main finding in relation to the patient's interactional contributions was that these patients were resistant to the message. Almost all patients showed some degree of resistance. Most overt resistance and some only passive resistance. Resistance were disagreements, rejections, challenges, and passive resistance would just be withholding affiliative moves. So if you try to explain something, so, you know, I think this could be brought on by stress, you know. At this point, you could expect the patient to say, uh-huh, or but if the patient just remains silent, that's odd. And it communicates something. Or just minimal acknowledgement. So, okay, you know, a bit of doubt. That would be passive resistance. I'll show you examples. This is the first. This is overt resistance.
Okay. Does that sound plausible to you? Do you think that it's reasonable, or does that sound very unlikely?
It sounds reasonable, but I can't apply it to me.
You can't apply it to you? Yeah.
There's nothing... I can't think of any bad thing that...
Yes, so there's obviously a difficulty here because you can't really think of...
So the doctor's just explained about stress and trauma, and the patient, you know, fully understands that this can cause problems, but not to him because he didn't have anything like that. So that's overt resistance to the idea. And here we've got passive resistance.
I don't know what other problems you've discovered. Do you go out the same as you did before?
No.
Your friends the same as you did before?
No.
See, you know, there are consequences.
Yeah.
And often then people think they're weird, they become isolated, they worry about approaching people, they become dependent more on others, they are much less of an independent person. And that can undermine them further. So sometimes it seems to come out of the blue and then just...
So you can hear the patient going more and more silent, and eventually he clears his throat in readiness to bite my head off. And in fact, what I'm doing here is something called a perspective display sequence. So that's what doctors do when they're in trouble. You know, it's when you struggling to communicate something. You want to communicate something different, like, you know, your child has intellectual disabilities. So instead of saying that, you may say, well, you may have noticed that, you know, your child's friends, they can walk now. You know, your child's friends can talk now. So you know, your child is a bit behind. So, you know, you state you try to engage the patient and try to get the patient to discover what you're trying to say. So that's what I'm doing here. So I'm struggling, and this is resisted, and it's met with silent and then throat clearing. So we looked at the distribution of this, and we found that it isn't equally distributed in the encounters. You don't find much of this resistance in the history-taking diagnosis phase. It's entirely okay for the doctor to say, this is non-epileptic seizures, hysteria, whatever. You can say it, you're the doctor, nobody's going to challenge you. But as soon as you start explaining, you know, this is a condition that has something to do with how you deal with stress, then you're stepping onto the patient's territory. They're the expert on whether they're stressed in their life or not. So they have a right, they have a ability to cut in and resist. And that's exactly what happens. And of course, if there is no, you know, there are no issues, then you're also going to struggle to sell the idea of treatment. And you're going to get even more resistance there. So as far as this paper went, it looked at the patient's contribution. It is objectively difficult. There is a lot of resistance to these sorts of discussions. And I should say, these discussions were essentially discussions that happened where the patient had video EEG, the diagnosis was done, and then they came for the 30-minute outpatient slot or even 15-minute outpatient slot for the discussion of the diagnosis and the recommendation of treatment. So what do the doctors do? Well, the main observation here was formulation effort. Silences, cutoffs, repetitions, self-repairs, syllable stretching. And this happened mainly when the doctors were discussing treatment and etiology, but interestingly also during the diagnosis presentation. So here is one example from the presentation of the diagnosis. In this case, this is from one doctor who doesn't like to give these conditions a name because he thinks that's harmful. So.
Right. Okay. They're more likely to be due, or they are due to the, things that, the way I put it is things that are in your life or have been in your life, and the way these things are affecting you.
Like pseudo-seizures, you're saying?
Well, kind of, yes. I mean, that's not a term there's lots of terms for these things, but they are the movements and by extension the turns, and we often capture just a bit of the turn. That's quite usual, actually. Yeah. As I say, they're not due to a medical illness, they're due to that kind of thing.
So there is formulation effort even before the patient's interesting interjection there. Okay, they're more likely to be due to, or they are, and so forth. And this doctor doesn't speak in this aphasic way most of the time, or in fact, it's entirely normal speech. But there is formulation effort here at this point in the encounter. And then when the patient suggests a label, he's completely at bay. So it's not surprising that this formulation effort, which demonstrates difficulties that the doctor is having in the process of explaining the diagnosis, that this is maximal in the etiology and treatment parts of this discussion. I showed you that that's when the patients are maximally resistant and when the doctor is trying to step onto the patient's epistemological territory. What's more interesting is that actually we see some formulation effort even when the doctor discusses tests or when they communicate the diagnosis. In fact, we saw quite a bit of formulation effort at the point where the doctor communicated the diagnosis. That shouldn't really be a problem. It's the doctor's prerogative to announce the diagnosis, but these doctors struggle, and that includes me. These are experienced doctors. At this point, they struggle to deliver the diagnosis without formulation effort. We also looked a bit at whether formulation effort was related in any way to overt resistance, which is easier to measure and to code for. And overt resistance on this graph, you can see all the patients there is in black. And the formulation effort or the level of formulation effort identified is in blue. And you see there's no correlation at all. So the doctor's formulation effort is not specific to the particular difficulties they encounter in a given interaction with the patient. It happens anyway, even in patients who are entirely accepting of the diagnosis. So, how are we doing with this standard approach of communicating the diagnosis of non-epileptic seizures? I said at the beginning that 1 in 6 patients become seizure-free. In fact, one of the doctors involved has published even higher rates of achieving seizure freedom by just explaining the diagnosis. He achieves this in 1 in 3 patients. So in favor, some people get better with this explanation and access therapy. It's clearly structured. And it's quick because it's a one-size-fits-all. All these 3 doctors follow different approaches, but each doctor was very much doing the same thing every time. And some patients told us afterwards they really appreciated this. Finally, they'd met a doctor who knew what was going on, and they were very appreciative and got a lot better, got a better understanding from these sorts of encounters. But there are also issues with this. This one-size-fits-all approach means that we are not really respecting patients' autonomy. We're just rolling out a communication program which has become routine. And several studies have shown that up to 40% of people are left confused by these sorts of encounters, and some are left angry. And of course, this approach does mean that some patients never access potentially helpful treatment. So in our program, we know that 20% of the patients who tell me, yes, please refer me to the psychotherapist, 6 weeks later, they don't go. They never show. So finally, an example of which may be a bit of a model of how we might do better and more ethically aware communication. So this is a case, lady I've called Sue. When I met her, she was 55. She was single. She'd never worked. She was on disability benefits. She had 3 actually grown-up children. And she was referred to me because she had refractory seizures and the previous neurologist didn't know what to do. In her history, up to the age of 35, there'd been multiple childhood admissions. That was apparent from the notes that I had about her. She was diagnosed with a fibrocytic condition. That's I think, a medically unexplained problem that put her in a wheelchair for several weeks as a teenager. She also had a road traffic accident with a head injury and loss of consciousness, although it's not clear how long she lost consciousness for, and it wasn't very severe. She took a deliberate overdose, and she was diagnosed with asthma. She had dyspareunia, and was treated with a hysterectomy eventually by the gynecologist. When she was 35, she had her first blackouts, which were described as unrousable, twitching all over, and this occurred in the context of what was thought at the time to be a panic or asthma attack precipitated by contact with her first husband. So actually the contemporaneous records displayed a relatively clear understanding that these were blackouts related to a highly stressful event. Nevertheless, she was started on phenytoin by the GP, who thought that actually this was hysterical, but he wasn't sure, so he'd started on phenytoin. And she then had more seizures, and because of that, she was referred to a very eminent neurologist. She had an EEG, which showed possibly a left sharp wave focus, and he thought the phenytoin was justified because he couldn't be sure either. Then, age 36, she was admitted with seizure status, followed by left numbness and visual field defect, which was a tubular visual field defect likely to be functional. She had a gait disorder, which was also thought to be functional and which resolved after 3 months. She had seizures in hospital, which involved loss of consciousness, breath holding, cyanosis, frothing from the mouth, twitching of the eyes, gentle twitching of the right arm, and she was unconscious for 20 minutes. So there are many markers there for non-epileptic seizures, but nevertheless, treatment with anti-epileptic drugs was continued. At one point, she was on quadruple therapy. Nevertheless, she had 2 seizures a week. And this went on for over 20 years. Well, just under 20 years. And then 1 year before I met her, my colleague looked at her again, did an MRI, video EEG, no major attacks recorded, but she did have a minor event with twitching and confusion without EEG changes. But the background EEG showed occasional sharper changes in the left temporal region. It's an interesting word of the use of the word sharper, which of course means less sharp than sharp. It's a comparative. It's presumably slightly sharper than sharpish. And I don't know where sharpened would be on this scale. But anyway, on this basis, treatment was continued with anti-epileptic drugs. Now, I did what I normally do, and these are pretty much all my contributions for the first 30 minutes. Could you tell me, first of all, what your expectations were when you came here? And then after 6 minutes of just going, I say, so sometimes there's a warning. Picking up something she said. Then after 9 minutes, can I take you back to the first seizure? Can you remember about when it's first started? 10 minutes, what about the last attack? 12 minutes, I pick up something she said. And then 14 minutes, what about the worst seizure you've ever had? 18 minutes, it's this challenge. When you are in this state, is there ever a situation where you can hear people talk but can't respond to them? Or are you completely out? And then there were some additional questions which were quite relevant, especially at the end. You said at the beginning that worry or family trouble sometimes made seizures happen more frequently. What's the connection between worry and the seizures? Is it immediate or is it just... So that's all the work. That's the good news. You really don't have to say very much. You can relax and enjoy the ride. I'm just going to give you a flavor of what the patient's, how the patient talked. This is a seizure description.
There used to be curtains, I don't know if it's still the same. And you used to go behind there and then you used to go through a door to see Dr. Davis Jones. I was actually just walking through, and this was, and I put them down to worrying again, because I was worried what, you know. But I was walking through into his study, into his room, when I just went. That was the first time. The second time, I was actually coming in here, and I had one on the lift coming up.
So I've spared you the first. There was a similar section where she just described the curtains. I've spared you that. Even in this bit, you can see that the focus is very much on describing the situation in which the seizure occurred. The seizure happens somewhere in the sentence, "I just went." That's all we ever learn about the seizure, and much of her talk was like this. She described many seizures, but very few symptoms. So in terms of what I said about the differential diagnostic value, she talks like somebody with non-epileptic seizures. But that's I've demonstrated earlier with our study that we know that we can do that. What I wanted to show you here was actually what happens with this sort of minimal questioning, what you can get out of patients, and how, when things go well, this can unfold. So I've looked at the transcript and I've picked out all the emotion words that she's used. Now this is in the first 6 minutes. You see that the only word she uses is worry. It worries me that I might be taking medication needlessly. One thing I would worry about is not having my husband with me. They brought it on by worry. I've got a lot of family worries. So there's a lot of worry in the first 6 minutes. And then from minutes 7 to 20, it becomes more specific. I'm being afraid. It's the only place I ever go without my husband. I never go anywhere without him because I'm too afraid. I can remember feeling very claustrophobic. Once again, I've felt caved in, an awful feeling. It's an awful feeling, usually when there's people around me. So she's becoming more specific. After 7 to 20 minutes, she is able to share quite interesting emotions, more complex, specific emotions than the worry she started off with. And then over the next 10 minutes, it becomes even more interesting. So we have a lot of guilt, because she was raped when she was a child, and then it makes me feel guilty. She's talking about her daughter. So when she sees her daughter have a bout of anorexia, she feels guilty. And then when she has to see a psychiatrist, she feels guilty. And then the guilt, the everything else, because I wasn't there for her. She's having a lot of mental treatment. I felt very guilty about that as well. That's where my husband says you could feel guilty over anything. So not only is she feeling guilty about a specific thing, she's actually feeling guilty all the time about a lot of things. So if maybe you can get psychoanalysis for dummies, maybe there is such a book. It's interesting how the defenses, how the better defended emotions come through a bit later, and how things become more specific and more relevant to her case. Now, separate to that, I've looked at the transcript again in a similar way, looking at how her illness theories developed in this interview. And remember, I'm not a psychoanalyst. I didn't ask many questions. I just gave her space to develop her own relevancies. So she starts with family worries, family problems, and then some specific sensory things like squares. If I look at a lot of little squares or little circles, they bring on seizures, certain videos where it's in black and white, if anything is in black and white. We're in the first 10 minutes here. Then it's blue light, then it's flashing blue lights, then it's health worries. When I go to hospital again, then I'll worry, and that'll bring on a seizure. Then there was the head injury. Then I was in a car crash. About 3 weeks later, I was kicked around the head. So I've never known which of the two things actually caused it. There's fatigue. All I know is that, they deprive me of sleep, this is. And then it becomes more interesting. And then the guilt. Then I start thinking about that type of thing, and then it starts sending me off, it's my own way of coping with it. Then it's constant guilt. It's because I'm thinking about it all the time. It never leaves me, and I think about it. It sets me off. I try not to think about it unless I have to. I feel guilty about anything. And then there's this curious reference to her two older children. My eldest two lads get in contact with me, then that sends me off on a roller coaster because she feels guilty. I'm not going to see them. I don't see them very often. So I think what we see there is that if the given time, this patient has actually developed quite a credible and useful illness theory of her attacks. But I think these consultations also contain a lot of markers of psychodynamics, so a more psychiatric view of what's going on using the biopsychosocial model. So I think there are indications here of dependence, of self-conflict. I'm the sort of person that don't worry about what may be, only what is. So she's normally strong. It's just when she has trouble, then she's very weak, and that's a conflict she's in. She's avoidant. She shows evidence of phobic avoidance. There's dependence. I have to have someone with me all the time. There is the physical abuse, overprotection. He won't let me use pans or boil a kettle. There's medicalization. To me, they were just blackouts, but not to everybody else. So the doctors took part in this. There's a very external locus of control. All I know is because they deprive me of sleep. So it's the doctors that do it here. There's dissociation. I can sort of hear them now. I don't know if I heard that, but I think I heard it. And of course, when people describe dissociation, you wonder about trauma. Although that wasn't really described here. Trauma doesn't feature directly, only guilt. Social phobia, depression in the context of guilt, avoidant coping, and rumination. People have said, will you stop thinking, stop blaming yourself? So has she told us everything? Not at all. Just one last snippet to listen to.
What about the worst seizure that you've ever had?
I think the worst seizure I can ever say I've had was when I actually drowned in the bath and had to be revived. All I can remember feeling there was I felt like a dizziness, and got this violent headache again. And I can remember thinking to myself, I'll have to root and get out of the bath. And the next thing I know is that the lodger, who was a boy, was a male, was knocking the bathroom door down. And he knocked the bathroom door down, shouting my husband. And my husband come down, and I can sort of hear that. Now, I don't know if I heard that, or if it's just that I've heard it being said that many times, that I think I heard it. I don't know.
So to me, this is all the features of something Freud would have called a Deckerinnerung. I've asked about the worst seizure, and what I get is what I would interpret as an account of a rape scene or something that covers a rape scene. There's clearly something going on with males. She builds up this. She starts with a lodger who, of course, doesn't have a gender, who was a boy. That's an infantile male gender. But then she tops it. He was male. So it's absolutely clear. This male breaks down her bathroom door while she's lying naked and exposed. So I didn't ask about sexual abuse, but in my mind, it was very likely that this lady had been sexually abused, and that put her guilt about her daughter in a particular perspective. So what happened to Sue? You remember she'd had 2 seizures a week for 20 years or so. After the interview, the seizure stopped. We stopped her anti-epileptic drugs, but she's completely free of attacks for 2 years without any treatment, because on the NHS you don't get treatment if you don't have a problem. I kept seeing her, not very often, every 6 months at first, then once a year, and then she came back 2 years later, and she had a range of physical symptoms, including what she complained about were unprovoked visual flashbacks of previous trauma, and then we did talk about her own traumas. She had also weekly blank spells, but she didn't come to hospital anymore, and these were not much of a problem and were not foregrounded by her. So at that point, I referred her for psychotherapy, and after 20 sessions of treatment, she's been much, much better. She looks like a Vietnam veteran when she comes to the clinic. She has a stick, and ideally she'd have a number of medals as well for her pains. She looks like a battlefield, but she battles on, and she functions now. So, some conclusions. On RED, I said that one can use ethical considerations. I'm sure that's obvious to you, to look at specific practices such as inquiries about sexual abuse. I think this can also be applied to history-taking strategies, and in fact it should be. I talked to you about selling the diagnosis and how our current communication practices really pitch patients against doctors. And I've shown you how doctors tend to follow a one-size-fits-all approach, which has much more to do with their previous experience. So they start having formulation effort before the patient even resisted, or when the patient is not resisting at all. They anticipate that it's going to be difficult and begin to flounder way before they've encountered the slightest bit of difficulty with the patient. And these are experts. And then in the case study, I've demonstrated how patient-guided communication can work and how it doesn't just have differential diagnostic potential, it has wider diagnostic potential. This patient worked out an illness theory. I worked out my own illness theory. We ticked off 20 different biopsychosocial potential factors which may have contributed to her disorder. And really my conclusion from all this is that it is our obligation, given that this is, in my view, clearly a more ethical way of approaching patients, to create an environment in which this sort of communication is possible. There'll always be excuses, like there's no time, or there's not enough money. But this lady was consuming large amounts of healthcare funding, and I spent 36 minutes talking to her, and seizures which had continued for 20 years stopped with that conversation. So, if we know that that is sometimes possible, how can we ethically waste our time with communications squeezed into 15-minute slots in which we try to be stronger than a patient and sometimes succeed? So that has come to me whilst preparing this talk. And I should thank all my collaborators, the many linguists who helped me and who are the brains behind the operation. Thank you very much. Okay. Question, I mean, we did aphasia tests. They're crude, but we did the kind of best bedside aphasia tests there were, and there was no difference between the groups. We also did something which I didn't talk about. We had a control topic specifically introduced to see whether there would be general speech difficulties, especially people with epilepsy. So we had at the end of the consultation, I said, so we've talked about lots of difficult things. I just wonder, before I go, whether you could tell me about things that you really enjoy doing. And there are no systematic differences. It is possible, indeed, that much of the conversation behavior that we saw had something to do with the fact that many of these patients had long careers as patients, and that their behavior may have been formed in interaction. Some of the patients had only had seizures for 2 weeks. There was a patient who was admitted to our hospital with status and then took part in the study. So we didn't see, we saw the same kind of things in that patient. The group in Bielefeld have done over 100 interviews. We've subsequently done interviews in other settings, and I don't think it really is a result of long illness careers. I think it is a dialect that people acquire from having that illness experience, not just the seizures, the whole shebang.
Thank you again for your talk. Dr. Reuber, will be here tomorrow.